Go. Good evening again. I'm Dr. van der Westhuizen. I'm going to be hosting this panel again tonight. Tonight we're discussing the opinions that are not obtained from Google University. We want to know if we can trust the science of vaccines. Basically, we want to know, do we vaccinate or not? At our last discussion, we definitely established one truth. We are all divided in our opinions and treatment, and nobody has the miracle cure. So our new panel are all people who have treated patients, successfully, and who have treated patients unsuccessfully. But we all have one goal in mind, and that is to save the lives of as many people as we can. And that should be all that matters. I hereby introduce my panel.
Good evening. Thank you for inviting me. I'm Dr. Edson Makamba. I'm a specialist physician and a pulmonologist.
Good evening. My name is Dr. De Villiers. I'm a general practitioner in Windhoek with a special interest in integrative medicine.
Good evening. Thank you for the invite. I'm Dr. Scholz. I'm a specialist physician and gastroenterologist, hepatologist.
Good evening. I'm Dr. Brewer. Also, thank you for the invite and the opportunity. I'm a pulmonologist and specialist physician.
Good evening. I'm Dr. Ziggy Basson. I'm a GP from the north, from Tsumeb.
Good evening, everybody. My name is Jean Maritz. I'm a virologist in private practice at Pathcare in Cape Town, South Africa.
Dr. Murray, could you just repeat that?
Sorry, could you not hear me, Stefan? So I'm Jean Maritz. I'm a virologist attached to Pathcare, the laboratory group in Cape Town.
Thank you.
And then Dr. Basson.
I'm Dr. Ziggy Basson from Tsumeb. I'm a private practitioner.
Okay. Welcome to all. Dr. John Murray, he's a virologist, and we're going to start with him just to explain a little bit more about the virus itself. Dr. Murray, the COVID-19 vaccine, how does it differ from influenza or the previous SARS viruses?
Just ask, is the vaccine or the virus, Stefan?
The virus.
Right, so essentially, if you want to compare SARS-CoV-2 and influenza, there are very little to actually compare. It's completely different viruses. Like you have different genera of bacteria, this is the same. They are not related in any way. The only, I think, kind of commonality is that they both can produce respiratory illness, but they come from different families within the kind of viral environments. Genetically, they are differently orientated. They don't share genes in any meaningful way, so they really are quite unrelated from a virological perspective. In terms of SARS, so SARS-CoV-1, if you will, but SARS, the disease we had about 20 years ago, they are fairly closely related from a genetic perspective, which is why there was so much concern when it was realized that this new virus at the end of 2019 is so similar to the severe acute respiratory syndrome virus, SARS-1. So they are all, so SARS, the first one, SARS is also coronavirus, but also just to kind of complete the picture, we also have endemic coronavirus. There's other things called HKU1 or 229E, for instance, that are just endemic kind of winter cold viruses. So there is a spectrum. That's what I'm trying to paint here. SARS-CoV-2 in that spectrum, but its closest relative that we have seen before is SARS-CoV-1 in 2002, 2003. Anything more specific you'd like to know?
Next question then, if some of these viruses are so similar, how accurate is our PCR test? Could you perhaps explain PCR? And in view of the withdrawal of that the CDC said is going to withdraw the PCR test, are we reading it wrong? Or is there anything else or could you explain more about that?
I'll do my best to keep this short, Stefan. So essentially, PCRs are really accurate. I mean, it's the most accurate diagnostic test we have available for viruses. I get your question and concern on the basis of genetic similarity. The way PCRs are designed is to focus on things called conserved genes, which are genes that are unique to the organism that you're trying to diagnose. You obviously don't want HIV to make an influenza PCR positive, but also then, as a second aspect, stable enough so that the sensitivity of the PCR is not compromised by mutations. Now, we've obviously seen a lot of viral variants. Those are on the basis of mutations. So when you set up a PCR, you try and look for areas in the virus that, as I said, are so unique, but also is in the interest of the virus to contact or to kind of maintain in its current form. Right. So when you make a PCR, you've got a few options, but the way SARS-CoV-2 PCRs are specifically designed with a view on keeping specificity as high as possible, which is what you're asking in terms of genetic relatedness. It chooses those areas as I've explained, but it also chooses multiple areas. So most of our PCRs we have target 3 genetically distinct areas of SARS-CoV-2. So not one. If you think of a general kind of influenza PCR, that really only looks at one genetic target. Most COVID PCRs then look at 3 targets, right? And you want them to kind of confirm each other, so it builds in more specificity. Some PCRs, however, only have 2 targets, right? So they might go for an S gene and an N gene, or an R gene and an E gene, but all of those targets are chosen to be unique to SARS-CoV-2. Something about the CDC. I think there is confusion about the statement that you just referred to in terms of the CDC retracting its PCR. I want to be quite clear that the CDC retracted their own PCR protocol, something called the CDC protocol. What the CDC protocol was a test they developed themselves. Essentially, it looked at one gene, but 2 targets within the same gene. So they only looked at the nucleocapsid gene. So when the CDC made their statement a few days ago, they said that they realize now that I think it's not as sensitive and specific as they would have wanted. And they do not retract the use of PCRs. They just said, please go for another FDA-approved PCR when you do diagnostics. Right. So it's one product that was removed from the market, not PCR as a testing strategy in the whole. Does that make sense?
Has the virus mutated more than other viruses? I mean, we are now by the 5th mutation. So why has it happened so quickly, or did it happen so quickly?
Yeah. It definitely did happen quickly, and I think it caught most people off guard. I think people anticipated that it will mutate. So maybe just going 2 steps back, it is an RNA virus. RNA organisms, compared to, let's say, ourselves as DNA organisms, have got less capability of correcting genetic mistakes made when copying a genome. So when our cells replicate, we've got good, or undergo mitosis, we've got good mechanisms to try and edit out, if you will, little genetic incorporation mistakes that our DNA replicase kind of machinery makes. With RNA organisms, that mechanism isn't really present, actually. So all RNA organisms mutate, and that's why you get things like antigenic drift, for instance, in influenza. It's the same mechanism. But like you said, there were a lot of mutations. We've seen mutations arising spontaneously in different countries across the globe. So that certainly is something that wasn't anticipated. The answer to your question as to why has this happened so quickly is essentially it's the product of 2 things. It is the chance of making a mistake from a genetic copying perspective, which I alluded to, but then also the sheer magnitude of replication. So if the virus wasn't particularly infective, it didn't spread from 1 person to 3 others in a susceptible population initially, or to 6 to 8 others as we have at the moment, we wouldn't have seen as many mutations, because it purely is a product of replication. So the more replication that takes place, the more chances there would be for a mistake to creep in, which means, and those are mutations, by the way, and that means the bigger the chance of a variant arising on the basis of those mutations. Right, so if we had fewer people infected, we in all likelihood would not have seen so many variants arising so quickly. Right, so it's a product of its own infectiousness.
Thank you so much. So now we're starting to get into the vaccines. What is the mechanism of working of the different kinds of vaccines. I mean, we have vaccines that work in different ways, old vaccines, new vaccines. Could you elaborate a little bit about that?
Sure. Again, I'll try to keep it succinct. Right, so when you vaccinate somebody with anything, you essentially have, I'll try to kind of bin it to keep it simple, more or less four approaches. So the first thing you can vaccinate with in virus terms is a live virus, a weakened or an attenuated but live virus. And an example of this would be a chickenpox vaccine, varicella zoster, or a measles, mumps, and rubella. They're all live, so it's live measles in the vaccine, but it's weakened so as to not to cause disease in an immunocompetent or general kind of immunocompetent recipient population. Right. So it's a whole virus in its kind of native form, but weakened through kind of essentially laboratory techniques. Then you also have whole viruses that are not live but are inactivated. Right. So this is the Sinovac, Sinopharm kind of approach if we talk about COVID. So maybe I can just go back a step. There are no live attenuated COVID vaccines in the market at the moment. So then the second one I started to describe, the whole virus inactivated. So as the name kind of, it says on the tin, it's the entire virus. It's as if you, well, not as if, it is virus grown in a laboratory on human cells called vero cells. The viruses are harvested from the kind of fluid around the cells and they're inactivated. And that then forms the basis of the vaccine subject. And then other things get added to stimulate the immune response and to preserve the concoction. But it is still a whole virus. Right, then you get subunit vaccines. And this is, for instance, if you have read about the Novavax COVID vaccine, that will be an example. Other examples would be hepatitis B vaccine that I assume all of us or most of us have had. So it's not the whole organism. It is only the little bit of the organism that will elicit an immune response, which then is meant to be protective. So Hep B, again, a very good example. We all were injected either at birth or when you were 18 years of age, going to medical school, whatever. With this preparation, you were given 3 doses, and kind of but you only expose the immune system to the little bit of protein that you want to elicit an immune response to, and you give it a few times to boost the response. Right, so that's a subunit vaccine. And then you get kind of engineered vaccines in a sense. So this is where the mRNA or DNA vaccines come in. So for instance, examples would be something like Oxford AstraZeneca or Janssen Johnson Johnson, which uses a viral vector. But the point of the vector is to deliver a piece of SARS-CoV-2 protein transcribing DNA to our cells to make the protein. And if you consider that as kind of a chain of events, an mRNA vaccine is very similar in the sense that it enters just a little bit later in that chain. So maybe just to put those two things together, if you got a Janssen vaccine, or Johnson Johnson vaccine, you have this replication incompetent adenovirus that is delivered by injection, and this delivers a piece of COVID spike protein DNA to your cells. Your cells make mRNA, and from the mRNA, the spike protein is produced. With an mRNA vaccine, you just don't have the first half of what I just described. Essentially, it's the mRNA that enters the cell with the use of other kind of immune attractants. And from that mRNA, you make spike protein, which is then again what ultimately is the subject for the immune response. Okay, so I think I'm going to stop at that. If you have questions about any of what I've said, please ask. But maybe just to keep it simple, I'll stop there.
Thank you very much. I think that is exactly what we wanted to hear. The next question is directed at Dr. Brewer and then also Dr. Marie again. So we want to know what's the difference between natural acquired immunity and vaccine mediated immunity. I mean, that means, so how long does natural immunity last compared to the vaccinated one? And do we have any research on the timeline? Dr. Brewer, perhaps you can start with that, and then we can go to Dr. Marie again.
Very sure. Thank you, Stefan. Yeah, I think one I should differentiate between natural immunity and vaccine-acquired immunity in what we can predict. I think that's the easiest way to try and describe it. So, with naturally acquired immunity, we know that once you get infected, your body will elicit an immune response, and this immune response will then be influenced by various factors. For instance, if you were taking steroids while you were infected with the virus, your immunity might not be as strong as one would expect if you weren't taking steroids. And then also with perhaps your inoculum, the amount of virus that you were exposed to, and various other factors. So your natural immunity, there's various factors that play into how robust this immunity develops. How long it lasts, I can't give you an exact answer. We know that probably at least for 3 months, and most likely for about 8 months natural immunity lasts. And then after that, in some people it will wane away. Some people will develop immune memory. Now, what's the difference in vaccine-induced immunity is, firstly, you don't have to have the infection, so you don't have the complications of the infection by being vaccinated. But also the vaccine is a controlled way of stimulating the immune system. So we know that with a certain dose, we can give a certain robustness to your immunity. We can stimulate your immunity and make sure it is more robust, and thereby hoping that or knowing that the immunity will last longer. And I think, yeah.
Marie?
It seems that the upper limit at the moment is about 8 months for protection. I almost don't want to call it immunity because it's hard to really define, because the immune system is so, or the immune response is so variable. But I think we know that it's in, for instance, people with a milder infection, it is more difficult to prove the presence of, or the continued presence of antibodies for a longer period of time. So they do seem to wane more quickly, and then in a way it's linked kind of to the immune stimulus with the dose of infection that you had. I think there's something I would like to add on the difference between vaccine-induced immunity. So again, I just want to add to what Willie said. So it's definitely obviously controlled. I mean, absolutely. You have the ability to expose the immune system only to the bits that you, or to expose to the immune system only the bits that you really want to. So the spike protein in this case. I think one of the biggest overlooked advantages of vaccine versus natural protection or immunity is I think we forget very often that with all viral infections, there are immune evasion or immune subversion mechanisms employed by the virus to blunt your immune response. So for instance, and by the way, there are quite a few utilized by SARS-CoV-2. Something like CMV also has an immense amount of mechanisms that it tries to use to essentially blunt our immune response to it to survive longer, which makes sense if you think from the virus's perspective. So with SARS-CoV-2, as an example, it downregulates our major histocompatibility complex, or MHC class 1 molecules. So it literally hamstrings the cells to present its protein, let's say spike protein, to the immune system. So it really is blunted. Like, it keeps all of the stuff in the cell without properly exposing it to our immune system. With vaccines, you don't have any of that. There are no combative mechanisms from the vaccine side trying to kind of hide itself from the immune system. Everything is geared towards exposing as much to the immune system to generate as kind of broad and as intense or good a response as you possibly can get. And I think that's a very important factor to highlight. That is, in my mind, one of the biggest differences between the two states. Thanks.
I'm going to get back to you a little bit later with that question that you didn't want to answer, and I will ask that question to Dr. Brewer as well. But let's get to the rest of the panel now. So, Dr. Scholz, Dr. Basson, and Dr. de Villiers, why not take a chance on natural immunity? And is it really necessary to, when you have had your illness, or when you went through COVID, to really go and vaccinate again? I mean, you have survived it, so why not take a chance on natural immunity? And then the second part of the question is, when do we have to go back and immunize after we have had COVID? Let's start with Dr. de Villiers.
Thank you, Dr. Westhuizen. It's quite a good question. I think at this stage now, with most of our population that's been this, or big portion of our population being exposed to the SARS-CoV-2 virus, there's a big question about getting immunized or not. And this is a personal opinion, it's not medical advice. But I feel that the rate that this virus is adapting or mutating, look, the sole purpose of a virus is to spread its genetic material. And it's going to find a target and it'll do it better and better and quicker and quicker. And I think with the first wave, our immune system maybe was quite capable of catching the virus, recognizing the virus, responding to the virus, having a proper immune response. But what we've seen now with our last wave, which was mostly Delta, if I understand it correctly, was just that the immune system was totally overwhelmed. So and we have to understand that immunization is just part of this whole toolbox of tools that we have for a multi-pronged approach to protect our bodies. So washing your hands, wearing masks, social distancing, and immunizing, making sure that your vitamin levels are right, making sure that you are using everything in your ability to prevent infection is essential. And I think we've just seen so many people that have been overwhelmed with this last wave that, for me, I would say vaccination is a critical tool at this stage. It might not prevent infection completely. It might not prevent spreading of the virus completely. It might not prevent you from ending up in hospital or dying completely, but it definitely, and we see it in the numbers, it will definitely prevent you from ending up in, or lower your risk, let me put it that way, lower your risk of ending up in hospital and dying. We see it in England now, we see it in Israel, where they started up picking up numbers again after vaccination. Those are countries that have been 60, 70, 80% vaccinated. And now, yes, again, they've got a rise in numbers of infections. But if we look at the number of hospitalizations and deaths, that it doesn't, it's much better as in the past. You're not seeing that spike of hospitalization and deaths anymore.
Thank you, Dr. de Villiers. Dr. Basson, what's your take on this?
Predictable outcome of the disease to acquire natural immunity against the very predictable outcome of the vaccination. I would rather choose the vaccination because that is much more predictable, and a lot of people die from the disease in the process of getting immunity, where less people die from the vaccination. And yes, I think people still need to get vaccinated even after they've had the disease. So anything from 2 weeks to 3 months after the disease, they can get vaccinated. But for mostly for 3 months, they should be well protected after the natural immunity. So they still need to get vaccinated, even after having the disease.
Dr. Basson, Dr. Scholz, I know you've been, your family and your practice has been hit very hard with COVID.
You lost your secretary, you and your husband both were very sick after having one vaccination, and you still go back to take a second one. Can you elaborate on that, perhaps?
And thank you, Stefan. I think the question of getting vaccinated again after infection has been answered by Dr. Moritz. Our best protection in this fight against getting severely ill, and also putting an end to this pandemic is vaccination. And I think whatever we've seen in other drugs has not been as effective as the vaccination. So you want to make very sure, even if you survived COVID, that you do not get a subclinical infection and infect other more vulnerable people that infect more people, that we really start taking responsibility and making sure that our immune system is geared best for the fight against the spread of this virus. And unfortunately, we've got a tool and that is vaccination. And it has been shown very clearly in the world data that the pandemic is hopefully now dying a slow death, because our economy, especially in Namibia, the tourism sector, the worldwide is on breaking point, I think. So it's not only the people that die. Obviously, we don't want to lose these important people that we've lost, but also there's much more to the pandemic. There's much more responsibility than just preventing deaths.
Thank you so much, Dr. Scholz. Dr. Makwamba and Dr. De Villiers, I want to ask you again. So you've immunized. Which vaccine did you take? It is often said that do what I say, not do what I do. But I think in this case, I think people would be more eager to get a vaccine that the doctor has gotten. So which vaccines did you get, and what do you advise your patients on getting? Dr. Makwamba?
Thank you for the question. I was vaccinated with J vaccine in February. And my advice, I think, to the viewers is any vaccine that's offered to you is a good vaccine. Whatever you are given, you take. And I think some of my colleagues here have already highlighted the importance of getting vaccinated. And the reason why I get vaccinated was, one, it prevents infection. And this has been shown in many studies that those people that get vaccinated, their chance of getting infection is reduced. And the reason why you want to prevent infections is we have seen what you call post-COVID syndrome, and these are lingering symptoms of COVID that persist for long periods of time. Most people have persistent coughs, persistent chest pains, shortness of breath, fatigue, which is just running out of energy. And in the event that you get infected, your chances of passing the virus to the next person is also reduced, because your chances of being very infectious is also reduced. And what the vaccines have also done is they reduce hospitalization, they reduce deaths, and they reduce admissions in ICU. And the importance of having this is it reduces bed pressure in hospitals. It's been heartbreaking, I think, of late, seeing patients that are presenting with stage 4 cancer who couldn't get the care that they could have gotten if the beds were empty or if the beds were available in hospitals. People with immunosuppression who can't access their treatments, people with chronic conditions who can't access treatment and therapy from their doctors because the hospitals are full of COVID patients. So I think it's important that people get vaccination so that at least the chances of getting infected is less, the chances of passing the virus to the next person is also less, the chances of getting admitted in hospital or landing in ICU is also reduced. And above all, the chance of dying will also be reduced.
Thank you, Dr. Makwamba. Dr. De Villiers.
So I had COVID in May, end of May, beginning June. And I didn't have it too severe. I had a bit of sinusitis symptoms, night sweats, no shortness of breath. And I recovered quite quickly. I do, however, work in a facility where we manage COVID patients. And as we all know, that the risk of passing from COVID, especially at the elderly, is quite high. So for me, it was very personal because in the beginning I said, look, I'm a scientist, I'm a father, I'm a doctor. Looking at the vaccinations, it's new technology, fairly new. It's been around for a while, but it's fairly new. And the long-term data wasn't available in terms of safety for myself. Short-term data in terms of short-term risks after having the vaccination, your risk of having a complication from the vaccination is quite little. And after about a month and a half, 6 weeks after we had this wave of patients just being admitted and having no beds, patients lying at home, dying at home, not having enough oxygen not being available. So for me, I was lucky enough to have access to J&J. I took a single J&J shot. I took it because it was available at that stage, and probably because it's a single dose. For me, it's difficult to get out of the practice, and there's also this idea of not being able to have the second dose in the near future, potentially. So I must say, a very good friend of mine works in Cape Town, in Paarl. They had the same situation last year that we were in now. And he said to me, there were 3 days in his life that he had this absolute euphoria. The first was his 2 children, and the second one was having his COVID vaccination. And it does give you the sense of safety, I must say. But like I said, it's part of the tool, it's part of the toolbox. It's not going to prevent you from falling ill 100%. It's not going to prevent you from spreading the virus 100%, if I understand it correct. But it'll keep you out of hospital 93%, up to 93% lower risk of ending up in hospital, and a 90 or 95% lower risk of ending up in ICU and dying. So for me in my hospital setting where I'm working with a high risk exposure to patients, COVID patients, for me it's definitely worthwhile having that extra safety net.
Thank you, Dr. De Villiers.
Yes, I think it's very important that the public out there knows that we have also struggled with the question, should to vaccinate or not vaccinate, and basically the whole panel, me included, we have all been vaccinated. It was a personal choice, but we've done it as well. It's not that we weren't scared of the side effects, but in the greater picture, I think it's a chance that we took. Because we work in hospitals and we are potential carriers to carry it to our families, and I think that for me was one of the things that why we all did it. Yes. So the next question is the difficult question. We're quickly going to have a break. We have a small microphone issue. We'll be back in a couple of seconds. Sorry, hi again. Yes, so Dr. Marais, I know we actually decided to perhaps not answer this question, but I think it's very important that there has been this fear that the vaccines actually are causing the spike in our or in COVID. So could you explain to us what is vaccine-induced viral enhancement and this so much feared protein shedding that the community is talking about, and also some medical practitioners are spreading?
Okay, Shay, it's not that I'm not willing to answer. It's just that I think it's a really complex. The first aspect that you've mentioned, Stefan, especially. Let's talk about the shedding thing first. I think it's shorter and easier to address. I have absolutely no idea where the idea of shedding of protein of a virus comes from after following the vaccines that we have access to. If you have a live organism that is infecting you, you can spread that. I mean, that's the mechanism for that by which SARS-CoV-2 spreads. But that implies that you've got an organism that replicates and makes more of itself, which is then expelled, by coughing or sneezing or whatever. If you don't have a replicating organism, you can't you can't expel anything. You can't shed anything. Even more so, if you only have a subunit, right? So let's say we had an inactivated COVID vaccine like a Sinopharm again or Sinovac, like because it doesn't replicate, it doesn't make more of itself, it merely is presented to your immune system, there is literally nothing that you can cough up. There is none of it. It doesn't go to your throat and sit at the back, and if you do a PCR, you'll find it there. It just doesn't work that way. Even more so if you think of vaccines or engineered vaccines where it literally only is a piece of protein that is produced, again, on which your immune system acts to make these protective responses. There is absolutely no way that you can shed anything. You can't pick up protein if you were to, let's say, swab the throat after a vaccine. It simply doesn't exist. So I don't mean to play down the fear. I just really want to. I've tried to understand kind of where the fear comes from, but I must say I'm a bit dumbstruck because there is no mechanism, and I actually like if somebody who is afraid of this can explain the fear to me, because it really is not founded in science, and therefore it should not be a fear that anybody is afraid of or concerned with. And also maybe just if we think that this is driving the pandemic. I don't think there's been enough vaccine doses in the countries that are represented tonight to make that case. I mean, we see so many infections. We haven't covered a lot of the population with vaccines, so surely that's not the big driver of a spike in cases. Okay, then the more difficult one. So generally speaking, kind of the enhancement that you're referring to is called antibody-dependent enhancement. So it has been seen previously, which I presume is the basis for the fear. Years ago, in older vaccine candidates with different technologies, there have been case reports, and I think what likely ties this to SARS-CoV-2 most closely is the fact that in a rodent model, so really not a human model, a rodent model of SARS-CoV-1, the thing that died out in 2003, there was evidence of antibody-induced enhancement. Okay, so I want to distance that from SARS-CoV-2, however, because firstly, it's not SARS-CoV-2 we're discussing, it's a different virus. And secondly, it was seen in a rodent model, not in a human model. It was never replicated in the human. There are no case reports of, let's say, confirmed antibody-dependent enhancement even of SARS-CoV-1, never mind then SARS-CoV-2. So it is a kind of almost a highly theoretical kind of concern that even if we have one or two cases, it's not a common thing. It will never be. I mean, how many millions of doses of these vaccines have been dished out without any case reports of this having happened? So we're practicing evidence-based medicine. That is what our advice should be, as medical practitioners and scientists, should be based on. And there is, to my knowledge, no evidence of a case of antibody-dependent enhancement following a SARS-CoV-2 vaccine. I hope I didn't miss anything, but even if, like I said, there is in future one or two cases, it surely is not something that is very common or that is driving a spike. I think this can be a very long discussion, and one needs to understand what the basis of antibody-dependent enhancement is. And with the vaccines we currently have, I mean, they don't lend themselves towards that mechanism based on the fact that they have the ability to generate high levels of neutralizing antibodies. And the antibody-dependent enhancement effect is more commonly seen in non-neutralizing antibodies, such as you commonly see after a natural infection. So I think, yeah, Stefan, do you want me to discuss this further, or is it okay?
Um, um, give his view on that, but thank you, Dr. Murray. It was really quite enlightening. Dr. Makwamba.
Yeah, so I think, yeah, like Dr. Murray have already pointed out that antibody-dependent enhancement hasn't been seen in SARS-CoV-2. This was described in viruses like Ebola, dengue fever. What happened with the dengue fever was this was mainly in children that were infected with dengue. When they were reinfected, they noticed that most of them would get fever or would get what we call dengue hemorrhagic fever, and most of them would die. And there was confusion at that point in time as to what was really causing it. That's when this antibody enhancement started to come in. What they then discovered was those that had previous antibodies to these viruses, they will get severe disease. And the postulation at that time was people with those antibodies will quickly neutralize or attach to the virus, and that virus will then be internalized into the cells and then start multiplying and then cause severe disease. This was also noticed in viruses like Ebola and with the HIV vaccine that was using adenovirus as well. Now, because some of the vaccines are using adenoviruses like adenovirus 5 and adenovirus 26, many people expected that you probably might have the same antibody dependent enhancement, but this hasn't been seen with the SARS-CoV-2. And the other form of antibody-dependent enhancement was getting a severe disease or a severe inflammation that would then lead to death.
Thank you, Dr. Makwamba. I've learned a lot tonight. Dr. Brewer, can you give your opinion?
Yeah, thanks, Stephen. I mean, I fully agree with what the previous speakers. And I think what one just has to highlight is that the process is not getting, if it was supposed to be that antibody-dependent viral enhancement happens, that it's not like if you get infected, you will spread it more. The actual thing that will happen is the carrier will get more severe disease. Now, we haven't seen that in practicality. I mean, on the ground, I know we only had, with our last wave, we probably didn't even have 5% of our population vaccinated. But even in that, we really did not see that many patients who's even had one dose who was severely sick. We had a few, but really the numbers of severe infection in fully vaccinated cases were absent. I'm not aware of any, maybe one or two that I'm not aware of. But ultimately, I think the important thing is that it's not applicable really to SARS-CoV-2, as we've heard, and on the ground we're not really seeing it at all.
Thank you, Dr. Brewer. So we're going to go a little bit away. We focus on not the vaccine, but the treatment of the initial COVID. And we're going to ask our panelists, Dr. De Villiers, Dr. Scholz, and Dr. Makwamba, and Dr. Basson, just to tell us, what is your current advice on what should a patient do when initially diagnosed with COVID? How has the treatment of COVID changed over the last 2 years that we've been dealing with it? And then I'll come to the second part of the question just after you've answered the first part. Dr. Basson, can we start with you?
First, I see the people in the first line. The important thing is if the people get a positive COVID test or they suspect COVID, I think it's very important to get a healthcare or practitioner involved. These days, many go to a pharmacy or anywhere else, they do a quick test, and then they just leave it at that. It's very important to go to a doctor and to, after that, to isolate, of course, do the apply to the rules of isolation. When they come to me, I usually, in the beginning, I want to know exactly when their symptoms started, so we know where we are in the disease. And then initially, I prescribe immune boosters and mainly symptomatic treatment. It's also important to get your other comorbidities under control, the diabetes, the hypertension, the asthma, or whatever, to have that well controlled. And then I like to follow up my patients, usually around day 7 or 8. And I explain to them in the beginning that the first phase is usually not the phase which can cause much, although not the dangerous phase. It's the viral phase, but the dangerous phase is the inflammatory phase. That is where we often see the saturations dropping. So I advise them, if it's possible, to control that or to measure that. You can get a little oximeter at the farm, or you can even, on some phones, you can even download an app if your phone is compatible to measure the oxygen. And then they must contact their doctor when the saturation drops below 90. I think the treatment has changed. There's a lot we have learned. Fortunately, we are almost at the end of the world here. So the whole thing hit us a little bit later than China, Europe, America. So I think they did a lot of pioneering work regarding the treatment. So we are fortunate that we know a lot about treatment which works and what doesn't work. So yeah, that's regarding the initial treatment. But as I say, it's very important that you do have a doctor looking after you, knowing about you, that you are COVID positive, because otherwise you get lost somewhere and you treat yourself. There's so many home remedies, so many prescriptions from friends, from family, from the internet, from YouTube and Facebook. People are very confused. And please let your doctor know what treatment you are taking if you treat yourself at home.
Thank you, Dr. Basson. Dr. de Villiers, how's your treatment changed over the last 2 years, or has it changed?
So this can become quite a lengthy discussion. I think what we're doing tonight is one of the most important things. I think patient education needs to start very, very early. We have to realize that there are basically two types of patients in this world, two types of people. It's a person that's had COVID or a person that's going to get COVID. Just ask around who's not had flu, who's not had a cold in their life. It really doesn't exist. So, and this virus is not going anywhere. So the initial education, getting the patients ready for this virus and infection, I think is extremely important. I think personally I start with vitamin C supplements and vitamin D. We find in Namibia 7, 8 out of 10 people are vitamin D deficient. And there's a lot of data that shows there's a direct correlation between low vitamin D levels and severe disease, specifically with SARS-CoV-2. So we start vitamin C, zinc, vitamin D, and this is something that we can take on a regular basis, daily basis as a matter of fact, to prepare your immune system for this infection. Then, the same as Dr. Basson said, for me, early intervention is very important. We find that people that come later in the disease, people that have stayed home, that didn't want to bother the doctor, that didn't take the time or effort or to go and see the doctor, those are the people that really struggle. The first 5, 6, 7 days of this disease is critical to treat and treat properly. After day 7, 8, 9, now we've spoken to Dr. Brewer a little bit earlier, day 10 it seems now when this hyperacute inflammatory process starts in your lungs and your blood vessels, it becomes extremely difficult to treat. So I would say as soon as if you feel ill, and you'll know it's a atypical infection. You might have just a sinusitis that doesn't want to respond to your normal treatment, but you've got back pain or fever. or night sweats, then you need to test. It's important to have that initial test that you know where you're standing. And if you test negative and your symptoms are still atypical or typical for SARS-CoV-2, then you retest and you retest. We've had patients that ended up in ICU with 3 negative PCRs, and they are still treated as COVID patients. So aggressive initial treatment, making sure that you contact your doctor early in the disease, and that should keep you out of hospital. I always say at my hospital, my job is keeping the patients out of the facility, not admitting them. And we've been fairly successful. We do obviously have our patients that we catch late and they end up in hospital, they end up in ICU, and they do pass away, unfortunately. But we've been lucky enough to have a lot of time to prepare for this wave. So that's, like I said, there's lots and lots more. I see there's a question about pulse oximetries. Don't know if it's part of this question, but I might just...
It's the second part.
Second one. Okay.
You can answer it.
Now?
Yeah.
All right, so at some stage, a couple of weeks ago, it was really, really difficult to get a bed in hospital, in any health facility. Patients were lying at home on oxygen bottles. Patients were lying in casualties, being used as ICUs almost. And if a patient called me, the first thing I would say is, go to your pharmacy, get your preventative medication or supportive medication, and get a pulse oximeter. Because if you're symptomatic and your saturation stays above 92, 94, then you should be fine. A lot of patients present with back pain and headache, and that's a totally different pathology. But as soon as it drops below 90, then you know that you really need to make sure that you contact the doctor, even if you're lucky enough to see your physician to assist you.
Thank you. Dr. Makwamba, you are very involved with the patients in ICU. How's your treatment changed over the last 6 months, 12 months?
I think I would just start with the treatment in the outpatients, patients that are being seen in the outpatients. I think there hasn't been much in terms of treating patients that we're seeing in our rooms and send back home. There are only, I think, 3 drugs that have been approved by FDA that have been found to reduce hospitalizations and progression to severe disease, especially in people that are above the age of 65 and those with chronic conditions. And these drugs, we call them monoclonal antibodies or biologics. And there are 3 of them. Unfortunately, we don't have access to them in the third world. But to those that have got money, those drugs have been shown that they will reduce progression to severe disease or even hospitalization. So for those of us who have money, I think you can inquire with your general practitioners or your specialists about those drugs, especially if you're being treated from home, as these drugs have been found to reduce your chance of developing severe disease or even being hospitalized. And in the event that you have been hospitalized, what we have been doing over the last year or 2 years is, once your oxygen levels have gone less than 92 and you require oxygen, and your inflammation markers are high, we have been using CRP as one of our inflammation markers. What we have been doing is to give a drug that we call remdesivir. It's an antiviral drug. This drug has to be used very early, especially in the first 7 days, but most of the time we use it on admission in hospital. And those that have got inflammation markers that are high using CRP, the recovery study used a cutoff point of 75. Once your CRP is above 75, we give another biologic drug or a monoclonal antibody called tocilizumab. This drug attaches to one of the markers in the blood that we call interleukin 6 and reduce that inflammatory process that usually starts around day 7, day 8, day 9, which then causes clogging of the lungs and leading to ICU admission and everything. And this drug has been shown to reduce that chance of progressing to ICU admission or even death. And one of the drugs that have been found also to be effective are steroids, and we usually use dexamethasone. In those that don't have dexamethasone, hydrocortisone or methylprednisolone are also alternatives. And these drugs have been shown to reduce your chance of dying, and even your length of stay either in ICU or in hospital. So these are the main drugs that have been shown to reduce mortality: tocilizumab, baricitinib, and dexamethasone. Remdesivir doesn't reduce your chance of dying, but it reduces the length of stay in hospital and ICU.
Okay. Dr. Scholz, would you like to add
Just a few words to this question.
I think I've been disappointed with colleagues who, convincing patients that there are alternatives to what Edson just elaborated on. And I think we have to remind ourselves where we are. It's more philosophical now. In this day and time, we live in a world with billions of people we've very, very successfully developed modern evidence-based medicine, which we can see. Our children survive. We've tackled pandemics. We've tackled all the major killers until now. And I think we can trust modern medicine, that modern medicine does work. And there's been a lot of confusion created, and I think that a lot of by medical staff, and I think a lot of our patients have sadly been misled and maybe could have been saved if people would have stuck to what we taught. So that is something that has upset me. People should have been told to do the things that are right, that have been done worldwide. We've seen, like Dr. Besson says, we've had the luck of having a delay with our pandemics. Pandemic here, main pandemic, the Delta virus pandemic to the rest of the world. So there was a lot of opportunity to learn from the other countries who've had very bad dealings, and still people don't believe it. That's my take. Thank you.
Okay. Yes, thank you very much, panel. There's one last question. I believe that we all are trying to help patients, and I think there's a big difference between being a general practitioner and seeing the patients at first hand, and then being a specialist and really seeing the very, very, very sick people. Dr. De Villiers and Dr. Basson, I'd like to go back to you and just tell us what your problems were when you started to deal with these patients. I mean, how did you start, and what questions would you have had to like, and what support would you have had to like in the beginning? We start with Dr. Basson.
Well, the situation with us is we're in the rural areas, so we're not close to Windhoek. We don't have specialists close by. Our hospital management of the private hospital, they really acted proactively last year already. And when it hit us, our first wave actually was in December, which was actually the second wave. They made plans, and now with the third wave, they made more plans to get more beds available, for which we are really very, very grateful. So fortunately, we didn't have to turn anybody away from hospital. But now people are getting clever, maybe at home. They also want to be proactive. They get pulse oximeters, but they often also get oxygen concentrators, even oxygen cylinders at home. My problem with that is people tend to treat themselves at home. Now the oxygen, they know they must check their oxygen levels. Now it starts dropping. They put themselves on the oxygen concentrator or the oxygen cylinders. And we know once a patient is really on oxygen, those cylinders don't last long, especially if you have to go to higher flows of oxygen to keep the saturation above 90. So it can be a very nerve-wracking situation. And you do need to have a doctor involved if you are doing that. But it's very nerve-wracking because what happens is often we miss that point where the inflammation takes over. And we need to start more intensive treatment with the cortisones, with the blood thinners. So that is what happens. And then the people come to us too late. And then they've already passed that critical point. So yes, to watch the oxygen with the oximeter is very important. It's one of the very important tools. I've seen patients that are very, very dyspneic. They are very short of breath, but the oxygen levels stay above 94, 95. And then other people, they seem very calm, not short of breath. And when you measure the saturation, it's below 70 often. So you can't just go on the symptoms. You must measure the oxygen levels. But if the oxygen levels drop, then you must contact your doctor. And that is where we prefer to admit the patient so we can start with a full treatment. Otherwise, we miss them. And as I say, it's really a terrifying experience at home for the doctor, for the family, for the caregivers, for everybody, to have these very sick people at home and trying to treat them. And then somewhere there's a turning point and then it's just difficult. And we often have problems to find ICU beds for our patients, to refer them. And we have to phone everywhere around the country just to find beds for these people. And often we don't find beds. And that is very tragic. It can end really tragically with that. So it is really important to stay connected to your doctor, to be under supervision of your doctor and to know what's going on. And we need to know what treatment are the people taking at home. They take a lot of home remedies and other remedies which we don't know about, which can cause problems.
Dr. de Villiers?
So I think I want to go back to the basics a little bit, just that this whole talk that we're having now is to inform patients about what is available, what they can do to help and to prevent, not to spread fear and to tell them where we're going to end up with them. We have to understand there's no standard care yet up to date for these patients. The patients vary in response to the disease, and there has to be a specific genetic reason for this. We see it, each and every person differs in terms of response. But I think that we've been around, I've been practicing medicine long enough, and if you practice integrative medicine, then there are certain medications that we do know that prevents infection, that is directly correlated, or deficiency of that is directly correlated to enhanced disease or increased risk to disease. And I think what we can do as practitioners is to put these meds together for patients. Patients buy immune boosters. If you look at the combos, it's usually vitamin C, vitamin D, zinc, maybe not in the right dosages. And I think that's our role as private practitioners or as general practitioners, as to guide them how to take this medicine. We very often see that people overdose, taking a vitamin C combo, then taking vitamin C on its own. They end up with tummy problems, burning tummy, diarrhea, and so forth. So from the doctor's side, I would say a structural approach, guiding your patients is very, very important. Sticking to basics with these medications, not to overdo it. The meds that Dr. Edison spoke about, yes, it works, those things works, but by the time the patient ends up in the hospital, very often it's late. Our patients tend to stay at home for too long at this stage. And there's a lot of stuff that people do. Initially, I was very uncertain with this whole steaming story. People steam with Vicks and steam with Anaconda and so forth, and there's merit in it. I don't prescribe it for my patients, but there's a concept called naropharyngeal or nasopharyngeal hygiene, where people would steam and then prevent this virus from spreading in the rest of the house, or using sanitizers, fogging the house, or leaving windows open. So like I said in the beginning, it's a really a multi-pronged approach. And I think general practitioners should educate their patients how to manage patients at home, because they're not always able to admit those patients. How to prevent family members from falling ill if somebody else in the house falls ill. How do you isolate a family member? I just think there's so much information, and we'll see now. I think when we look back in history, this will probably be one of humanity's biggest failures. And hopefully in 5 years' time, we look back and doctors would smile and say, yeah, see how easy it is now. At that time they struggled, but it's so easy to manage it now.
Thank you, Dr. de Villiers. Our last question before we take some questions from our viewers is to Dr. Scholz and Dr. Brewer. Dr. Brewer, you can start with that. Why is it that most specialists don't support the use of ivermectin? And this is basically because there's an apparent lack of evidence. But they recommend that we take vaccines, which has also only been started quite recently.
Well, thanks, Stephen, for your question. I think if we listen to what the whole panel has been discussing tonight, is we really try to focus on the things that we feel there's good evidence for, and that good and robust evidence for. And I think in this case there's a misconception. I think the misconception is that the vaccines were rushed through, they were not properly researched, and that the evidence is lacking for the use of vaccines. And I think that's a misconception. As I said, there's been very good studies about the use of the vaccines, the efficacy of the vaccines. I mean, they've been published in our top journals. For instance, the New England Journal of Medicine has a lot of publications. I mean, the first publication that was done last year, June, July, around there, on the AstraZeneca as well as the Pfizer vaccine. I mean, they had over 43,000 participants in that study, and there's subsequently been many studies. Yesterday there was a few more studies published that's high quality, good evidence for the efficacy of the vaccine. Whereas for ivermectin that you've mentioned, and I think there's other drugs that fall in that same category. I mean, we've heard about hydroxychloroquine initially. These studies was supported initially with some anecdotal evidence and maybe some small studies that weren't properly done. We've had the experience with ivermectin specifically of studies being retracted due to what the publishers said was ethical lapses. So unfortunately, I think Arno also earlier mentioned that we would love to have something that prevents and that works, and we don't know all the evidence, but what we do know is that we have to trust the ways Barbara mentioned it as before, as the ways we've been taught. Look at the level of evidence, what is the quality of the evidence, and what is best level of evidence, what works. And I think unfortunately that's lacking for ivermectin. It's lacking for something like hydroxychloroquine. It's there for things like dexamethasone, as Edson mentioned. It's there for the monoclonal antibodies, and it's there for the vaccines. And I think we have to use these drugs that is available to us either in a therapeutic or a preventative manner.
Okay. Thank you, Dr. Scholz, do you want to add something? We've got a few questions from the public that we'd like to go through, but if you could quickly just answer this.
I just want to mention one thing. The thing is that we don't need data anymore from top medical journals to see if the vaccine works. If you go to a website called World Data and you follow the rate of vaccination that happens throughout the world, Canada has vaccinated over 90% of its people, Germany over 50%, the UK over 50%, and you see when the vaccination curves have gone up and when the deaths have fallen, they coincide. So we have got a massive cohort out there of millions and almost billions of people. We don't need data in journals anymore. We just need to look at the statistics, and they have not been falsified. These are facts. People are not having to wear a mask overseas anymore. So it is very evident that the vaccine works. I haven't seen any big data. I think the biggest study was 500 in Argentina about ivermectin. It's been shown not to make any difference, but worldwide ivermectin hasn't been tested. But the vaccines have on their own shown to have a massive effect on the mortality and hospital admissions, and will buy us the way back to our freedom and stability. Thank you.
Thank you. So we've got a few questions from the public. The first one is, do vaccinated people have less chance of transmitting the virus to other people than unvaccinated people? Dr. Mokwamba?
Yes, so vaccinated people have a less chance of getting infected. This has been put in the range of, so with the ancestral strain, which is the first strain that was there, your chance of getting infected was probably 20%, and with the Delta variant, this has come down to about 50-60%, which means you have got a 50-60% chance of getting infected. In the event that you get infected, you have about 80 to 95% chance of having severe disease, an order of 90 to 95% chance of getting hospitalized, and then again 95 to 98% chance of, or less chance of dying. So vaccines are very efficacious and they work. And I think I advise everyone who hasn't been vaccinated to get their vaccines.
Thank you. Dr. De Villiers, a quick question. If I boost my immune system with vitamins, is it then still necessary to get vaccinated?
It's like I said, it's a multi-pronged approach. It would depend on your age. And like I said, this is my personal opinion. It's not medical advice, but age is an issue. So if you are younger than 30, I would think twice. If you have comorbidities, even if you're young, if you're hypertensive, if you're diabetic, if you have lung issues, if you're HIV positive, most definitely. It has definitely shown to reduce your risk of getting infection or getting severe disease. But having a optimal vitamin D, vitamin C, zinc level is essential for normal healthy lifestyle. So for normal healthy life, vitamin comes from the word vita, which is vital, and amine, which is a substance. You need those to have a normal healthy life.
Thank you so much. I think we've come to the end of our discussion. Just a quick closing comment. I do think that we all want to help our patients, and I think we've learned a lot tonight. I also think that it is necessary that we work together as general practitioners, as specialists, and definitely as the public, because the end goal should be that we again want to walk around without masks and feel safe wherever we go. Good night. Thank you to all the panelists.